Good morning, good afternoon, and good evening, everyone. Thank you for joining us here today for the WONCA Working Party on Digital Health webinar series. My name is Hüsna Sarıcı-Çevik. I'm the Training and Capacity Building Workstream Lead of the WONCA Working Party on Digital Health. I'm an Associate Professor of Family Medicine at Ankara University in Turkey with a joint appointment this year at Western University, Canada as a visiting professor. I'm very pleased to moderate today's session. And this first webinar is part of an international webinar series on digital health in primary care. With this series, we aim to support family doctors and primary care teams in understanding and integrating digital health into their everyday clinical practices, as well as sharing practical and evidence-based insights globally. Just some housekeeping items before we begin. Please keep your webcams and microphones off for the duration of this session. And if you have any questions for the speakers during any part of today's program, please feel free to submit your questions via text using the Q&A tab. Our working party deputy chair, Edmund Lee, and I will be keeping an eye on there and collecting your questions for the Q&A session. Please note that today's session will be recorded and later shared on the WONCA Digital Health website, so you can review it later. And please note that the Q&A part will be removed from the recordings. Today's session has two parts with expert speakers that we are honored to have them to share their insights. Dr. Ana Luisa Neves will be our first speaker on part one, Digital Health in Primary Care, exploring impact on quality and patient care. Then we will move to part two, Patient-Centered Care, keeping it human in the age of AI, where Dr. Maura Stewart and Dr. Keith Thompson will be joining us. And it is now my great pleasure to introduce our first speaker, Dr. Ana Luisa Neves. Dr. Neves is the chair of the WONCA Working Party on Digital Health. She is an associate professor and director of the Global Digital Health Unit at Imperial College London, and also a practicing general practitioner in the UK. She will be setting the scene by looking at how digital innovation may influence quality of care in primary care. After Dr. Neves's presentation, we will have a very brief Q&A about this first part, and then we will move to the second part of this webinar. Anna, thank you very much for being with us today. The floor is yours.
Thank you, Hüsna, and thanks for joining, everyone. I'll share my slides. Hopefully you can see the introduction slide now. Can I just get a confirmation that you can see my slide? Yeah.
We can't see it right now.
Not yet.
Okay, let's try again.
Oh, it's coming on. There we go.
There we go.
Okay, perfect. Thank you so much. Thanks, Hüsna, for the introduction, and thank you so much to all participants and the speakers here today. It's our greatest pleasure to start with this webinar series, which we hope can act as a community of practice and bring us together on discussions around digital health, and most importantly, also serve as a potential resource, educational resource for those willing to know more about the topic. So the way we envisage this is really not as a lecture, is really as a space from which we can learn from each other. So our role here as speakers is really just to start giving us some prompts for the discussion and to also learn from everyone's experiences in the ground. So this first part of the presentation, I'll take a couple of minutes just to go through why it's important to measure the impact of digital health on quality and safety of care, and ultimately how it impacts patient care. And I'm sure that Keith and Moira will dive into more detail about patient-centeredness, which is such an important aspect of quality of care. So we are operating in a world that's changing rapidly, and is changing rapidly in the context of primary care. It's a shifting landscape in which we are talking about a move from treatment to prevention, about patients that are becoming more and more empowered, but also patients that need to navigate this complex new ecosystem where both digital technology and digital information is becoming more and more accessible. We're also talking about a primary care scene in which the burden, both global and local, of preventable conditions is increasing, as well as the complexity of the patients that we are serving. So digital transformation emerges here as a potential opportunity to overcome these challenges and to make things better. But of course, it also comes with certain challenges. And something that we know for sure is that if we really need to maximize and to embrace its full potential, we need to get it right in what concerns implementation. And implementation is about structure, technical, financial, regulatory structure, but is mostly about how patients and providers are actually able and skilled to embrace it in the best way possible. So primary care is changing from a population-wide approach to a personal approach to care, from a clinician-led approach to a co-creative approach to healthcare, in which patients have a more and more engaged and proactive role, but also from care that's less and less reactive and tends to be predictive and participatory. And that means that we will rely more and more in data. And we'll discuss more about how data can be a potential source or a potential tool to engage and to increase the way we serve patients, but also how this data comes with its own biases and its own limitations. So I don't need to convince anyone in this talk, because there's a selection bias on the people presenting today or attending today, that technology is already changing the way we practice. And it's changing in a range of examples which affect directly or indirectly primary care. We're talking about diagnostics and screening. A lot of the systems in place in what concerns imaging. I'm talking about breast cancer, lung cancer screenings. Many of those programs already embed AI layers to try to understand what's normal and what's abnormal. We're talking about decision support tools, which could be what we recognized in the past as clinical decision support systems, but are expanding into a range of other resources. For instance, databases that become more and more searchable by GPs and other clinicians to understand what's the best diagnosis, what's the best treatment. And very importantly, is also encompassing solutions that support self-management and monitoring. So for a long time, we have been relying on data that's collected in these discrete contacts of patients with healthcare. But we know that increasingly, the relevance of this data is actually collected through wearable devices and sensors. And one of the most ubiquitous sensors is really the phones that we carry with us all the time, and in which we are inputting our information in what concerns lifestyle, behavior, risk factors, etc. So the question is not whether it will change, it's how will we be able to make the most of this change. So I'll use this presentation just to go through a few examples that can hopefully spark discussion for the Q&A. So when we try to reflect how do we get innovation right, it's a lot about implementation. It's not really about ideas, it's about how we make this idea work in practice. So one of the first points that I wanted to raise here is that digital innovation, and that goes beyond AI, and it's a broader concept really, is really a multidisciplinary collaborative effort. And that means engaging with patients. That means not working for patients, but also working with them in the development of the solutions that matter the most for them. So that brings me to the second point about the importance of co-design and participatory approaches. So people need to be involved in digital innovation from the very, very beginning. So this is about asking users, patients and providers, what are your needs? And as excited as we might be about digital innovation, we need to understand or to develop things that actually match their skills, match their needs, and match the system as a whole. And I'll get back to that in a second. So I'm going to share with you an example of an exercise that we did with patients. And this was really following up some research in which we were curious to try to understand how patients and how the public felt about sharing their electronic health records and information contained within it for public health purposes and for research purposes as well. So the question that we had back then was how we really engage with people in a way that's interesting, that's exciting, rather than sitting them in a room and just make them go through a formal exercise of a focus group. So what we did here is, and the reason why I really like this example is because it focuses on gathering the public views, but also it's a really interesting example of multidisciplinary collaboration and how research and design can work together to convey the message in a more effective way. So what we did here was, rather than staying in our research bubble, we partnered with a team of designers for healthcare research. And we told them, look, the question we're trying to answer is this one: how do people feel about data sharing? And what we don't know is how do we have this discussion in a way that's interesting and engaging for the public. So together we came with this idea of an immersive exhibition. So we created this small exhibition, a really small space in which patients were able to enter and to explore the space. And basically what they had there were some recordings of stories when data sharing went particularly well or went particularly wrong. And we build on a concept that you might be familiar if you are an English native speaker, which is the concept of a can of worms. So when something is quite sensitive, we prefer not to touch it because we would be a bit afraid that if we open that can, we'll have basically a bunch of worms coming out of it, a little bit similar to the Pandora's box concept. And our concern about asking people how do you feel about sharing your data was exactly the same. We were afraid that if we ask about it, we'll get all kinds of difficult questions and difficult discussions to have. So we built on that concept of can of worms, and we literally gave the public cans, which they would open. And when they opened the can, they would listen to the story of a narrative, an episode about data sharing going well or not so well. So this was a way of engaging with the public, of activating them to think and to reflect and to maybe criticize the way things were. And at the end of the exhibition, they were asked to write their main hopes and fears about data sharing in these cards that you can see on the slide and just put it in a wall. So what's happened here is that we collected data for research purposes, but this was not really a formal research exercise. So we were evaluating how digital innovation could help these people without actually making them go through a painful and sometimes a bit boring exercise. So what we did after was we took this data and we actually published it as a paper. So it's really an example of how we can do things in a bit of a mixed way, which can still gather data, but actually engaging public in a way that they feel part of it. So the question really is, how do we navigate this wave? How we actually can understand or can support the growing demand for innovation while understanding that some people might really not want it? And how do we ensure that there's a parallel route? Let's say in this specific case, if some people want to share their data, how do we enhance access for that? But at the same time, how do we protect those that don't want to use the data for those purposes? And that principle is applicable to a range of other things. We have discussed this quite a lot around virtual consultations, which have become mainstream, but still, for a group of patients, might not be the best option, might not work as well, might not be as safe, or maybe all those conditions are met, but still they don't want it. And that preference needs to be preserved, needs to be protected as part of one of the core competencies of primary care. The other point I'd like to raise was and is about existing inequities, and something that's very fundamental to digital innovation, and is a very core concept on digital innovation, is we know that by definition, when we push innovation into the system, the first ones to adopt it, to engage, to sustainably use are those that already are in more privileged positions. So what this is a concept that has been coined as the digital divide. So by definition, we know that by pushing innovation, we will be entrenching existing inequities. We'll be creating benefit, we'll be creating advantage for those that are already in an advantage position in the system. So what this really tells us is that we need to acknowledge this from the very beginning. And from a design phase, from an implementation phase as well, we need to think about how can this be innovation tailored to different groups of users, to different needs, so that actually doesn't entrench, doesn't aggravate these existing inequities. That brings me to the point of how do we measure if it's working? How do we know if it's working and for which people? And there are some general discussions, for instance, around the topic of AI, which is, of course, very hot at the moment. How can we know if innovation, AI, digital solutions work? And what I really recommend here is that we need to take a step back and move from these very general topics, from these very general concepts into specific solutions. We won't be able to claim that innovation or AI or digital health improves people's lives, but we might be able to say that certain solutions for certain groups of people in certain contexts might help them to have better quality of life and better health outcomes. So I'm bringing back this framework, which I think is really, really helpful. Obviously, when you try to do digital innovation, our core motivation is that somehow we will improve quality of the system. The problem with the word quality is that it's relatively subjective. And many people have struggled about how we measure quality. So this framework actually breaks down quality in 6 domains, which you can see: user experience or patient-centeredness, clinical effectiveness, health outcomes, efficiency, is it a good use of our resources, human, financial, safety, is it actually safe to use compared to usual care, is it equitable, and is it timely? So when we ask ourselves, why are we pushing digital innovation in the system? Or when we try to evaluate the impacts that digital innovation is having on the system, these sort of frameworks make it really clear to define specific outcomes and therefore specific conclusions of what is working and in which context. Something that we are lacking when we look at quality is really safety assessments. And this has been a gap because digital innovation has been so quick in some cases, sometimes jumping ahead of regulation itself, that we really start engaging it and start using it without having a proper assessment of whether it's creating safety issues for the population that is serving. So this is a fundamental aspect of assessment of digital innovation, which is understanding how do we measure safety, how do we compare it with usual care, and that usually requires having access to real-world data so that we can objectively measure safety impacts. This question cannot only be answered with data. Of course, we also need patient perspectives and user perspectives about their perceived safety, but data is a really key component here as well. I'll wrap up by reflecting on how we manage this tension about the hype and exciting about digital innovation with our hope that it will still preserve the core values of primary care. And this brings me back to the point that I previously addressed about digital innovation being a tool to address specific needs of the system. And that requires a very meaningful and a very honest exercise of understanding what are the problems that really matter in primary care. And from those problems, trying to understand what is the solution. Might be digital, might be something else. And what often we see is an exercise that goes the other way around. Sometimes we are so excited about digital that we just try to make it fit as a solution to a specific need when sometimes might not be the specific solution that we need there. And the really interesting example there is the use of SMS, text messages, which is something really old, really frugal, and it's still one of the most effective digital innovations or digital interventions that we can see from an evidence generation perspective. So I guess my key point here is really, if we want to measure, we need to move away from general concepts and go to these specific actions and specific interventions. And as excited as we might be with the concept of artificial intelligence, what I really think would make a difference would be move from the concept of artificial intelligence and start thinking about specific applications. Is it machine learning? Is it looking at numbers, understanding how these numbers can help us to predict pathways? Is it about patterns in language, which you'll recognize with use of large language models and chatbots? Is it about translating voice into text and hopefully getting out of our shoulders the burden of documenting, summarizing information? Is it about identifying patterns on images and help us to understand more quickly what is a visual diagnosis for lung cancer, breast cancer, etc.? So only if we move into these specific solutions and specific case studies, we'll be able to say solution X is actually improving patients' lives for the better. If we remain on the artificial intelligence umbrella, we'll only be able to remain in very high-level conversations that might not really be actionable. And I'll end up with this reflection, and you might recognize this quote is a pop culture quote, which you might have seen elsewhere. And the authors claim that we don't want the AI to write our poetry. We want it to wash our dishes so that we can still write our poetry. And I feel that is so applicable to the way we operate in primary care. And one of the key challenges here for us now is to understand how can we get AI to wash our dishes from a clinical perspective? What are the low-value tasks? And that those can be documentation, automation, background work, operational work. How can we actually get it focus on those tasks so that we can protect the core values of our profession, empathy, patient-centeredness, and hopefully making the patient remains the core focus of the work that we are delivering. So with that note, I will move into implementation and end with a final reflection on how can we make this work in practice. And the key message here is really innovation doesn't work on its own. It will be plugged in a system. So whenever it's designed, we need to understand if it really fits the system. And it should fit the system in a seamless way, because otherwise it will be perceived as another clunky part of the system that doesn't really add value. It's just another click, it's just another pop-up, it's just another burden for the physician and for the patient as well. So there are a lot of opportunities, but there are also some challenges that we need to reflect on, and these are a list of them. I talked about data. Whatever we do with data is only going to be as good as the quality of the data itself. This data is often fragmented, is often across different platforms, is often not speaking to each other, and these platforms are often not speaking to each other. We know that our biases in data, and this is a quite fundamental issue with AI or machine learning solutions that rely on these data sets. If different populations, different ethnicities, different groups are not represented equally, these tools are going to aggravate existing bias. We need to evaluate it. We need to understand what works for which patient in which context. And there is really limited work on this area, which needs to be expanded, particularly in what concerns safety. And we need to get right the infrastructure. And infrastructure are the usual suspects around privacy, regulation, governance, but very importantly is also about readiness and training. We need training to support patients. We need training to support physicians. And also like to reflect on a specific point about training, which is training as a role here, but really solutions need to be user-friendly as much as possible. If they are user-friendly, think about the usual things. Think about social media, think about large language models. The population broadly didn't require really any sort of training because they were A, perceived as a need, and B, they were very user-friendly. So people were just able to crack on there. So I will finish here and I will hand over to Husna to introduce the next part.
Thank you very much, Anna, for this excellent presentation. To make the most of our time, we will now move on to part 2. While part 1 focused on digital innovation and quality at a broader level, now part 2 brings us to the human core of primary care. It also connects powerfully with this year's World Family Doctor Day theme, compassionate care in a digital world. We have 2 expert speakers in this part, and it is now my great pleasure to introduce Dr. Moira Stewart, Distinguished University Professor Emeritus at the Center for Studies in Family Medicine at Western University, Canada. She is one of the leading scholars in patient-centered care, and her work has helped many of us better understand patient-centered care and why it matters in family practice. Dr. Stewart, thank you very much for being with us today. The floor is yours.
Thank you very much, Dr. Chevik. I'm going to share my screen and get started here. There we go. So thank you, everyone. I'm delighted to have such a successful beginning to your WONCA webinars on digital health. And this is already a success because you are here and there are many of you around the world. Thank you for coming. So I'm a research faculty member in the Department of Family Medicine. at Western University in London, Canada. And as a member of WONCA's Working Party on Research, and also as a past president of NABCRG, which is the world's premier primary care research organization, I'm honored to participate in this inaugural webinar sponsored by the WONCA Working Party on Digital Health. I'm really inspired by the WONCA vision found on your website of organizing family medicine and primary care according to Starfield's principles of first contact, continuity, comprehensiveness, and coordination. And to complement those organizational principles, which represent structures of care, in my view, we can also consider the processes of care, the one-on-one relationship of the patient and the family physician. And here, I'm going to introduce to you the philosopher of family medicine, Ian McQuinney, a person of the same generation as Starfield. Both were foundational thinkers. McQuinney spent the first half of his career in the UK and came to Canada in 1968, and much of his prolific writing has answered the question, are we on the brink of a new clinical method? A clinical method that describes how patients and family physicians solve problems, taking into account the whole person of the patient in context. Over the next 4 decades after 1968, McQuinney's protégés have defined this new clinical method and called it the patient-centered clinical method. So this lecture will cover the patient-centered clinical method in relation to technology. And I'm going to start by telling you what the patient-centered clinical method is and what it is not. It is not, in our definition, a health system integration, imagining seamless care from hospital home as one example. It's not a model of communication to be taught over here to medical students where clinical problem solving is taught over there. It's an integration of biomedicine, technology, and humanistic medicine. And it's about the encounter between the doctor and the patient. And all of these three, biomedicine, technology, and humanistic medicine, are needed for superior quality of care. So with that in mind, here's what the patient-centered clinical method incorporates these kinds of features. It includes the quest for diagnosis and cure. It includes the goal of caring for symptoms that don't have any diagnosis, the engagement of patient at the emotional level, the sharing of power, the goal of establishing a good relationship, and the integration of technologies to assist in both diagnosing and building the relationship. Here are the 4 interactive components of the patient-centered clinical method. This is a guide for how family physicians can solve problems with patients. 1, exploring health, disease, and the illness experience of the patient. 2, understanding the whole person. 3, finding common ground with the patient. And 4, enhancing the patient-clinician relationship. This diagram shows the 4 components together interacting with each other, and you can see component 1 in the upper left. Following the patient's cues, the clinician will explore these cues to the patient's views on their health, their symptoms, and their illness experience, their feelings and fears. Upper right, you see understanding the whole person as the person, their personality and their time of life, but also in their context, their family. In the center of the diagram, you see the central component, finding common ground, in which problems, goals, and roles of care are discussed and mutual agreement is obtained. At the bottom of the diagram, you see the foundation of a longitudinal relationship with the patient. Now, this version of that diagram we included in our chapter in the WONCA textbook on digital health. And this version shows 15 technologies that we discussed and their relevance to the process of care that we call a patient-centered clinical method. For instance, the first several technologies that we see in the legend You can see down the legend down below, it's telephone care, video care. Those first four are relevant to all of the four components of the patient-centered clinical method. Whereas wearables, which is E in the legend, is relevant mostly to component one, for example, obtaining results of home blood pressure and hemoglobin A1C monitoring. So I don't expect you to study this slide, but I wanted to make sure that it was in the slide deck for your future reference. I'm now going to say a few words to amplify each of these components, the four components of the patient-centered clinical method. So the first, exploring health, disease, and the illness experience. This is the patient's response when you ask, how can I help you today? The patient may express their cues to disease, oh, I've got headaches, or to their health, I'm no longer a healthy person. I actually want to be more active. And following those cues, not making a list of what we ask in our experience with patients, but listening for the patient's cues. You're going to listen for their feelings, their worries, their ideas, their wonderings, their function, and their expectations. I'm going to give you an example from my own life. I'm not a medical doctor, so my examples come from my experience as a patient. 10 to 20 seconds were taken to explore this patient's function, and this patient is me. So my own life and wonderful orthopedic surgeons. This is the story. I fell at the age of 71. It was no joke. I fell on the ice and I lay on the street at dusk and had broken my arm. But I was alone there for 6 minutes until a jogger came and helped me home. I had in 1 second lost my independence, my ability to take care of myself, my confidence in my body. Could I walk again? Would I lose my balance? Was it all over for me? After urgent care diagnosed me with a broken arm on the dominant side, which was painful and disabling, I experienced a week of ebbing confidence before I had my appointment with the orthopedics outpatient clinic. Well, they were wonderful. The orthopedic fellow took the lead. Well, tell me about yourself. Well, I'm a retired professor and I do research. Oh, okay. So what does your day look like? Oh, oops, I should have told you that I'm retired. So, okay. Well, what do you do each day now that you're retired? Well, I play music. Oh, what kind of music? I play percussion in big concert bands. What does that mean? I've never done that myself, says the fellow. Show me with your good arm the motions that you need to do to play your drums. Pause while I mimic with my good hand. And she says, I can tell you with your injury, having seen your x-ray, you will be drumming again within months. So this 20-second interchange took a huge weight off me and my broken arm or shoulder. The orthopedic fellow had started the conversation with my experience, the patient's experience, and the patient's function. And then we turned together to consider the x-ray and to consider the next steps. Turning to component 2, understanding the whole person. The clinicians listen for issues of the whole person, personality, stage of life, context, family, work, and finances, and even spirituality. Now, here's an example where technology played a role. Frida, age 66, had been with this Dr. S for 10 years, bringing migraines, diabetes, anxiety, depression, and fibromyalgia. And the doctor knew that she used a motorized scooter to get around. The physician learns at this visit that she's moved into a new apartment on the 2nd floor of her son's house. Asking permission to see the new home, Dr. S brought up a street view on her computer and noticed that the access to the 2nd floor was a wooden staircase on the outside of the building. Frida, how do you get up those stairs? Well, I leave my scooter at the bottom and I crawl up them. So this conversation gave Dr. S her first insight into Frida's reality and an impetus to find something more suitable for Frida. The third component is finding common ground. This is where the important information that has already been gathered about patients is brought together in a mutual discussion, and agreements are forged on the nature of the problems that are prioritized for today, the goals of treatment, and the roles the doctor and patient will play in the treatment plan. Agreements are forged. We know from Starfield's groundbreaking work that patient-physician agreement leads to positive patient outcomes. But also our own work has found, our own research has found that this finding common ground component is the most important. It directly affects better patient recovery. So the importance of finding common ground is really stressed by us. The fourth component is the patient-doctor relationship. What are the healthcare relationships that can unify and integrate? There are many such elements of the patient-clinician relationship, and I'm going to cover three of them: constancy, continuity, compassion, and sharing power. So this first aspect, Moreland says in her beautiful book called A Fortunate Woman, which I commend to you if you haven't read it. She says each of the interactions of the family physician is necessarily pragmatic and current, but they also have deep roots that over time intertwine the past with the present. And in my view, point-of-care technologies, which avoid referrals, increase the continuity of care. One of my colleagues here in Canada says point-of-care ultrasound creates a different and better level of patient engagement when you do this in your office, gratifying for the physician and the patient too. With regard to continuity of care, Dennis Pereira Gray has found in his review evidence that continuity of care is related to patient mortality. So it lowers patient mortality, and NOAC has found that continuity of care improves patient-reported outcomes and doctor satisfaction. I'm now going to turn to the second aspect of the relationship, compassion, and let you know that Brian Hodges, the former president of the Canadian Medical Association, has said, without compassion, there is no healthcare. And this is in his book called Leading with Care in a Technological Age. And this book expresses exactly what I'm trying to get across in this lecture, which is leading with care in a technological age. And here's an example from the Netherlands. Houwen's study in the Netherlands found that patients felt really uncomfortable when the GPs did not show empathy and compassion. Some patients with multiple unexplained symptoms, MUS, felt irritated when the physicians were busy looking at their computers. Anna has already referred to this. The patients wanted the opportunity to tell their story. And the final aspect of the patient-clinician relationship that I want to highlight is sharing power. And here's the way we describe it in the fourth edition of our book called Patient-Centered Medicine. Healthcare's role in reducing disparities and in providing a glue that helps hold society together has long been recognized. But there are a variety of mechanisms helping this role. And one is an ethical stance of sharing power. That is the belief that patients have a right to share in the decisions about their life course. And here's an example about sharing power regarding patient portals. From the patient's point of view, the patient said, each of us with our clinicians should have a conversation about how together we would use a patient portal. It doesn't need to be a long process, 5 minutes between us to figure out how that's going to work. So I've described the 4 components of the patient-centered clinical method, and I've used examples interweaving technology and patient-centeredness. And I'm now going to turn to what are the impacts of patient-centered care. And here I'm going to use the quintuple aims as my kind of organizing feature for the outcomes. What are the impacts of patient-centered care on health outcomes, the patient's care experience, costs, equity, and physician well-being? Let's start with health outcomes. And we see here that studies have found impacts of patient-centered care on mortality, on clinical status measures from pragmatic trials, and on patient-reported outcome measures such as physical health, function, quality of life, all again from randomized trials. But here's a testimonial from Dr. Gustavo Gusso from Brazil, who's actually one of WONCA's very active members. And he says, I think the patient-centered clinical method has saved many lives. And it's very interesting to ask him why he thinks that. Does patient-centeredness, I'm now moving to the second outcome, improve patients' care experience? And here we find that patients' experiences have been found to be influenced by patient-centered interventions, PREMs, or patient-reported experience measures, having to do with communication, patient-centeredness, quality, continuity, and coordination of care. We see in this next slide that patient-centered care does reduce costs. Cohort studies in Canada and the US, as well as randomized pragmatic trials, show this. Patient-centered care is a force for equity. Patient-centered care has been found to be a force for equity in Janney et al.'s studies, in that patient-centered care is effective at all levels of deprivation, supporting its unifying potential. What can we say about patient-centered care and enhancing the physician well-being? We have a new section in our 4th edition of our book called Patient-Centered Medicine in one of our research chapters, and it covers the 3 randomized trials that Bridget Ryan found, my colleague, and they all assessed a patient-centered training in relation to physician burnout and dissatisfaction, and all 3 of them found positive effects. And these results lead to me wondering and thinking in conclusion that patient-centered practice in family medicine can be an antidote to physician burnout. But don't take my word for it. I'm not the only one who thinks this. Dr. Keith Thompson, who we're going to hear from in a minute, says, we entered this decade suffering time constraints, finding ourselves distanced emotionally as we buried our noses in our electronic medical records. The art of listening became less important than the preventive care bonus code, updating the cumulative patient profile properly, or ensuring recent guidelines are being met. Distance emotionally, we now started suffering distance physically because of COVID, and both patients and providers are suffering the consequences. Hence my reach out to see if there might be some way of revisiting the principles of humanistic, compassionate medicine, which would be a redemptive and healing exercise, as I'm feeling as if I've lost a limb lately, trying to put sense back into our profession. On this inspiring note, I end this presentation asking you to consider focusing on the integration of technology and patient-centered medicine for the good outcomes that can be achieved for patients and clinicians alike. Thank you.
Thank you very much, Dr. Stewart. Your presentation has grounded us in the patient-centered clinical method, how effective it is, and reminded us that compassion, sharing power, patient-clinician relationship remain essential as technologies evolve. And building on this foundation, we now turn to everyday family practice in the digital era. As AI, EMRs, patient-facing tools, and clinical decision support systems become more and more present in our consultations, the key question is how they can strengthen rather than weaken patient-centered care. And now I'm very pleased to invite our second speaker, Dr. Keith Thompson, who will explore these questions. Keith Thompson is a family physician based in London, Ontario, Canada. He is the Chief Medical Officer at Neurologics and Adjunct Faculty at Western University Department of Family Medicine. Dr. Thompson is also a former executive board member of the WONCA Working Party on Digital Health. Dr. Thompson, the floor is yours.
Thank you so much, everyone. I am thrilled and humbled, honestly, to be here before the folks on this call. Some wonderful work. Ana Luisa, Edmund, your research through Imperial College and with WONCA is just astounding, and it's inspired me as well. And Dr. Stewart, as you know, my emotive email, which you referred to, was a beginning of a journey through an existential crisis, trying to figure out exactly how medicine and primary care may look in this technological age. I do want to acknowledge the First Nations lands I'm upon here in London, Haudenosaunee, Lapanewak, Shawniton, and Anishinaabeg. And we have a rich heritage with our Indigenous population here in Canada and still trying to reconcile. And technology is part of that, right? How we reestablish our relationships with those nations. I'm just going to give you the disclaimer, and my apologies for looking like I'm dressed for a mixed martial arts fight in that pose. I don't know what I'm trying to entail there, this persona of this tough guy. And I'm really not. I'm a family doc times 35 years who is a late bloomer to technology, some 35 years in practice. But when COVID hit, I was changing to my EMR from paper, if you can believe that. And it really became not only a crisis and kind of overwhelming, but it also became part of this journey to understand really what are the essential components of family medicine. I do want to lay out some disclaimers before I begin. So the biggest one being, yes, I'm Chief Medical Officer for Neurologics. This slide looks very busy, but pay attention to the main components, which many different technologies that I've used and experienced with, I'm not endorsing any of them, okay? These is my own personal journey. Your journey will be different. And the tools that you use in Europe and North America and around the world, the exposure to these different tools. And so really keep in mind, I'm not endorsing these tools. There are a couple of slides that I borrowed from Ontario Medical Digital OMD, which is also part of a working group that I participate with as peer leader, and our section for general and family practice here in Ontario, working group there on digital, but just some borrowing of slides with permissions. Let's talk about this gentleman, Dr. McWhinney, which you heard about. And, you know, this was required reading for me in my residency. And I was very much thinking, oh man, I just want to get through my exams. Like, I know this is wonderful, but this touchy-feely side of medicine, you know, I don't have time for this. I need to get to what's critical, understanding the disease and making a proper diagnosis. But at this point of crisis later in my career, I found myself going back to these foundational principles and really fabulous work that Dr. McWhinney laid out. And I start by just outlining a couple of things. He talked about the taxonomy of visits. Why do patients come to see us? Their limit of tolerance. Their ache, their pain, their itch. They can't stand it anymore. They just want relief. The limit of anxiety. They're worried about a particular condition. And certainly in this day of digital, when you see social media post about the 35-year-old who had a cough that wasn't addressed by their doctor and years later discovers metastatic cancer, I believe that's even a means of heightening anxiety, right? The patients are coming to us with these concerns. Heterothetic, the problems of living, the mom or dad who's stressed out at home and has issues and is coming to see us with a particular medical problem. The bulk of what we do, preventative care and immunizations, well baby checks, and of course, administrative duties. All of these require time. And so our digital health systems may not be giving us more time. It may be impairing the time that we have to do these various tasks. But beyond that, Dr. McWhinney laid out 9 foundational principles. And again, excited that you may have noticed WONCA is launching a campaign and speaking to these principles. And really what was a question for me is, how do these principles look in the context of digital health? So, for example, we know that family doctors, we make attempts at least to see patients in their homes. We do house calls. But how does that look now in the digital age? And maybe it's going to be data from a wearable, or maybe it's a telemedicine call into the home or a text message. Every encounter that we have is a chance for prevention or health promotion. I'll talk a little bit about that. So the data that's in our EMR, population health, who's eligible for preventative care and who should have certain procedures updated. The bulk of these principles, and I won't go through all of them in detail, but Dr. McWhinney put a lot of emphasis upon understanding the context of the illness. As we heard Moira speak of earlier, finding that common ground, right? The patient's trying to understand their illness. We're trying to understand the context of guidelines and what treatment there should be, and we're finding that ground. But what is it for the patient's world? And she gave some amazing examples of, how those two needs or understandings collide. And I think this has been fascinating to look at this and see how digital health may be helping or hindering in some cases these principles. With the group here at WONCA, and when I was participating within the digital health group, we brought this question forward, and amongst the group of us, we were able to revisit these principles and suggest actually 4 additional principles in regards to digital health and this advent of technology. And the first one was we suggested that family physicians understand patient digital literacy, and we adapt that consultation to enhance those relationships. Not every digital tool will work for every patient. And Anna Luisa referred to this digital divide, right? It's inherent that as we introduce these tools, there's going to be discrepancies between patient needs and how we're able to address them with these various technologies. As family physicians, we leverage digital knowledge and that democratization, not to be threatened by it, but to partner with. So for example, the patient comes in and they've Googled or even used ChatGPT or some other large language model. Doc, I think I have. And in fact, patients are even able to get some of their data and their lab results, and they're loading it up and doing very complex advanced queries. Are we threatened by that? Or are we able to partner with the patient and say, you know what, let's walk through this together? And so there's a bit of humility even in using these technologies. And I can tell you one other area we're interested in researching here at Western is how this comes into play with our own sense of agency or authorship, right? And we're exploring a little bit in the context of music. How does it feel as a musician or to have expertise in an area and have this incredibly powerful technology encroach upon that and output an answer or an example or create within our realm or domain? And how does that make us feel? The other last 2 comments, family physicians advocate for equitable digital health access. Again, the digital divide is growing, folks. And so, we design within predominantly urbanized center. Everyone has internet. I love the examples where you see, Anna, you referred to hype versus hope. You love those videos where they show the doctor and patient having a video call and, the screen capture is perfect and the patient's responding and giving their symptoms back and forth. And they run through this example of diagnosing a shoulder or a cough or URTI using video. And I've often said to my colleagues, okay, let's rerun that video, but now I want you to imagine that the patient has English as a second language, or they have a hearing impairment, or a sight, or a physical impairment, or they have a caregiver with them helping them manage the technology. Doesn't look so easy, and it's no longer that simple, right, when you put it into those contexts. And lastly, physicians prioritize compassionate relationships over those technological demands. That's why we're here today. The relations that we have with our patients. Look, the existential threat to family medicine is not the technology taking over our jobs. It's that slow erosion of the relational aspects of care. That's what makes our specialty unique. That's what's so important about family medicine. And that's what I'm becoming passionate about, right? And wanting to advocate. As technology advances, the world for the patient and the world for the clinician, they're a little bit different, right? Patients want to just understand, get instant health advice. They want to be able to book with us easily and go perhaps online and do portal access, right, to book their own appointments. I mean, we have systems now, and many of you have probably seen, that can interact with the patient, take the history, the triage. You think you're talking to a real person, and it'll actually just take everything and book an appointment for them. In terms of the information they're getting from their wearables, from their queries on the internet, the concern is that data reliable? And we've seen the dangers out there of false information that's being released, and where, and Anna, I love that taxonomy that you described, right? Moving away from just AI, but into the individual processes there. So yeah, is it a large language model just grabbing from the internet and it's grabbing information from a blog or gosh knows where? Or is it, railed in through peer-reviewed guidelines and very, retrieval augmented generative AI, right? Is very safe and perhaps more trusted and secure. And I think these are the questions that we have to ask. Certainly patients have a plethora of technology coming. Yes, they have wearables that they can start to gather data. They have self-management apps, remote monitoring that even is within the software as medical device you will hear about. Now, recently, and apologies to my European colleagues, the FDA is not the center of the world, but it feels like it sometimes when they make these declarations, and recently came out that what was once perceived a software as medical device, a bracelet capturing blood pressure, for example, or some other device capturing heart rate, etc., that would have been considered software as medical device. You need rigorous trials. You need to validate that data and have that device cleared through proper channels and control trials. They've said, no, you know what? You can now report some of these outputs and that can be considered a wellness device. So that's going to complicate our world a little bit as patients already, right, are bringing in their information that says, doc, it looks like I may have AFib, or it looks like my heart rate variability is suggesting I'm not sleeping well. What do we do with that? So in our world, obviously, it's more about that interface with the EMR, and we're using the scribes to capture the documentation, simplify the workflow, maybe sort documents. I have a tool I use in my office, and my medical assistant, she's ecstatic because now her inbox is empty some days. Mind you, mine is full and I'm drowning, right? But her day is freed up a lot of time. These clinical decision support tools and ways to make clinical decisions, automated billing, big structured data, population health, again, fascinating on how we're using this large data to change the way we interact with patients. And so we're no longer just gatherers of data. We're interpreting it and bringing us back to how we work through exploring with the patient and finding that common ground, exploring that illness experience for the patients. The technology captures very well their symptoms, their heart rate, their sleep, their dietary outcomes, etc. But it doesn't capture the meaning. Doesn't capture necessarily social determinants of health or what this means to them. So understanding the whole person, right, extremely important. And some of these algorithms can sort of flatten that. It's all about the ICD code. It's all about the managing the condition or making a proper diagnosis or proper treatment, and less about who that person is. In finding that common ground, right, the clinical decision support tools and coming to common decisions, technology can accelerate that. It can give us back that currency of time. I don't have to scroll through multiple fields to try and determine a recent guideline. I can simply speak to my phone and say, what are the suggested current therapies for condition X or Y? And how these technologies, AI Scribe being the example, how it may improve the relationship that we have by giving us back ability to have contact, eye contact, right? We're present. We're not just efficient. And again, word of caution, the system and healthcare systems pushing us towards efficiency, high throughput, lots of volume, get it done, but less emphasis on efficacy. And Dr. McWhinney, famous quote, he says, efficacy has that higher value. Efficacy takes time. And we're now speaking of this triad. We have in the room the patient, the clinician, and the technology, and how those three entities interact is really quite interesting. It's also opening up some domains, right, in terms of learners. I'm not an educator. I'm adjunct faculty here at Western. I'm a pseudo-prof. So I defer to the other experts on this call that are teaching residents. But, I'll propose this for you, that we're really looking at how do we measure some of these competencies, right? Maintaining eye contact, or recognizing when the technology is interfering with rapport, or being able to just explain the technology to the patient. Well, this is trained on a large language model or trained on data, like the patient's going to, like a cow at a passing train. Duh, what? And being able to have the power and knowledge to explain that in terms patients understand. And really contextual judgment, right? Integrating that social determinants of health beyond what's just in the EMR, and recognizing when a certain guideline or output doesn't fit. I want to give you one brief example of this that I recently had with my AI scribe. So here in Canada, again, our Indigenous populations, the original inhabitants of North America, and many of you may know the terrible history that we've had, right? It was an effort to colonialize and erase basically cultural heritage and history, and the residential school program. We're still catching up, and we have a lot of making up to do, right, to reconcile those past harms and ongoing harms in many ways, right, with our modern healthcare systems. And so cultural safety and training is part of that. Recently, a patient came in to me who was Indigenous from a local First Nation near to where I live. And I had explained to him this course I had taken and learning about the harms of colonialism and how the damages had been done. And we had this wonderful discussion back and forth. And he started to, feel a little more relaxed. And he's joking with me. He says, "Dr. Keith, I'm buying back my land, one load at a time." He was buying topsoil, and every load that came, he had to pay for. He said, "I'm buying back my land," right? At the end of that conversation, the EMR, the AI scribe, it formed out this beautiful note about his diabetes, the hypertension, and all the, wonderful. My soap note was complete. It didn't even mention the fact that he was Indigenous. It had no description of who he was, and all the joking and the conversation, the interaction we had, it became just fluff that it sorted out. Now, sure, I don't want to populate every progress note with, these superfluous details, but in this case, that was so important and so helpful to the relationship between myself and this patient, and trust was found. We're opening up a learning lab here at Western. We see it for advancing AI and meaningful solutions in primary care. And Husna, we are sorry to lose you. I know you're returning home through your stint here at Western. And thank you again for your help and participation. You're the conduit now between what's happening here at Western and ongoing work, I hope, with WONCA. But we want to study this tool starting with AI Scribe. And can we capture meaningful measures, right, to determine how this technology as an intervention in that relationship, what's going on? And maybe we observe these encounters and we'll be able to measure eye contact through video. We have some mock patients that will come in, and clinicians who will be recruited will run through a clinical scenario just as they would normally, and we'll look at that observational and some thematic and qualitative data really to determine how is this impacting patient-centered care. So we hope first step just to be able to build some methodology to capture some of these outcomes. It's going to be interesting, right? That even with our learners and some of the questions we might ask at the end of an encounter, what did the patient bring that this tool couldn't capture? Be it an encounter in the office, or with a wearable, or with a text search that they've done, or an EMR, a chat GPT or Google search. And as the example I gave earlier, where to describe miss elements of the illness journey, or who that person is, right? What's still lacking? I want to rock your world a little bit here, and just to share that, again, there are technologies as one, and there's many others like this. The patients have their own AI scribe. And so they will come in and, record during an encounter. What these tools do is put the conversation not into a SOAP note, which is our need, but into an understanding of their condition and their illness in the patient's literal terms, right? Or helping them understand. And I encourage the use of this tool. Now, the lawyers cringe. They're like, oh my gosh, what if their note differs from yours, Dr. T, and there's going to be a conflict? That's a valid question, I will say. And I joke that True standard of care won't necessarily be decided until we've had some civil litigation and we've hammered it out in the courts as to what these tools may mean for using them for clinical decisions or data gathering. New ways to diagnose. I mean, this is crazy. This tool recently FDA approved, I think last year before, auscultation. So trained on literally tens, if not hundreds of thousands of auscultation data on patients with ischemic heart disease. So a patient now comes in with chest pain. You can listen with this device, and with a negative predictive value well into the high 90s, 94, 96% negative predictive value. And please, those of you who are statisticians and epidemiologists will take me to the mat on some of the validity of that number. But suffice to say, it's a new way, if you think about it, a new way of diagnosing and interacting with a patient at the bedside. I mean, troponins and ECG and stress tests and all of it, yeah, that's not going to go away, but as a screening tool, right? How crazy is that we can now listen and derive some early diagnoses? Every encounter is a chance for preventative care. So population health, man, it's all about the coding. I'll tell you, the painful journey for me, because when I started my EMR, I was like, look, my CPP's up to date, the meds are up to date. Now, what's this ICD code? I'm not going to worry about that. Well, now I can't find my patients who have diabetes. I haven't properly coded, and it's difficult within my EMR. We have a number of different tools to do that. We have a local, through our Ontario Health program, where a team will come in and literally do a data pull. And they'll look at medications, look at A1C, using diabetes as an example. Be able to create a list for me. Keith, it looks like these are the patients with diabetes. And then I go back and apply that code in my EMR. So at least now I can confidently say, I know who those patients are. You know, international coding for primary care, and we're a bit archaic still here in Canada, sorry to say, right? We're stuck in ICD land. And a lot of this is the interaction between vendors and the health authorities that hasn't entirely been sorted out. And even the tools that I can use and access, there's vendor lock. I can only use certain tools because only some of them are compatible with my EMR. And the siloing of data, no reconciliation, I think that's a global problem. I'm sure I've heard conversations. I know that's not unique to Canada. You know, back to great, being able to see the data, creating a dashboard, understanding who my patients are with diabetes. Now what? I need help acting on that. So it's wonderful that you've got this great tool to show me who my patients are, but I need the support in interacting. And one example now, we have a program called Best Care, where patients who have COPD or asthma, in fact, she's here today, my respiratory technologist, who's specifically trained in health education. She's looking for those patients. We're bringing them into her, that she spends an hour with them, does pulmonary function testing in my office, by the way. So it's compassionate care by proxy. The time that I don't have to spend. And she goes through this condition in detail, explains to them when to use their antibiotic, how to use their puffer, etc. And so a really wonderful example of, yeah, I've got my data and the coding is in there and I know who these patients are. Now what? And I think that's where we're struggling sometimes, is those resources to support. Clinical decision supports, and again, I mentioned these here based on a Canadian, from a Canadian perspective. So my apologies. I know it may be different in Europe and other areas, but really, you know, we're seeing guidelines front and center, and even now buried within the EMR. And one question that's come up is, well, is that software as a medical device? If that large language model is creeping through my EMR and pulling up results from lab tests and listening to the conversation and proposing diagnoses, maybe that puts it into software as medical device because it's informing me or it's driving clinical management. You know, there's a certain amount of humility using these tools. I have to be able to admit that, yeah, it may know better or more than I. It's a bit humbling when the patient comes in and says, Doc, you know, I've reviewed my cholesterol and it says I should be on a statin because my target LDL should be this. It's like, oops, I didn't notice that, right? But again, back to that common ground and building trust. Last comment, two-screen workflow. I think, I don't like the idea of being locked to my workstation. I like some of these tools being on my phone that I can carry with me. I can go to a house call, for example, and turn on my AI scribe and capture the visit. Or if I have a clinical decision to sort out, I can bring up my phone wherever I am, so I'm not locked necessarily to my computer. So I want to thank you again, and for sure, I don't know everything. Don't quote me. And if I don't know the answer, you certainly can ask a large language model about that. So thank you, everyone.
Thank you very much, Keith, for your presentation. And you have really brought together the themes of today's webinar very nicely. And one key message I take from your talks is that technology, yes, can help us act faster, but not necessarily care better. So we need to protect the human side of care. Thank you, everyone, for joining us today and for sharing your questions. As we come to the end of today's webinar, we would also like to let you know that the next session of WONCA Digital Health Working Party webinar series will be on June 12th, collaboration with the European Young Family Doctors Movement. So please save the date. You can sign up and look up for updates on the event on your email. While poster is on screen, I would like to thank you very much to all our speakers for sharing their insights, for their wonderful presentations with us today. And thank you all participants for joining us from very different parts of the world. And again, apologies for these technical issues. Today's discussion has shown us that while technology continues to reshape primary care, compassion and human connection remain central to our work as family doctors and primary care teams. We hope you enjoyed today's session and found it useful. Thank you very much for your time, and we hope you'll join us in our subsequent webinars, and we'll see you again then.
Thank you.
Thanks, everyone.
Thanks, everyone.